Welcome. Before moving on to clinical diagnosis and management of glaucoma in the subsequent sessions, in this session we'll discuss some basic aspects of glaucoma, chiefly epidemiology and genetics. Glaucoma is defined as a progressive optic neuropathy, so ultimately glaucoma is a disease of the optic nerve, more specifically of the retinal ganglion cells passing through the optic nerve with characteristic loss of retinal ganglion cells and their axons, optic disc excavation and loss of visual field. And this definition of glaucoma is very important to remember. Significantly, intraocular pressure is not included in the definition of glaucoma. This is because there is no level of intraocular pressure which can help us to label all eyes with intraocular pressure above that level as having glaucoma and to label all eyes having intraocular pressures below that level as not having glaucoma. And in glaucoma, the main site of retinal ganglion cell death is said to be the lamina cribrosa of the optic nerve head. Intraocular pressure is a continuous risk factor over its entire range, which means that risk of glaucoma exists at a very low intraocular pressure and the risk of glaucoma increases with increase in intraocular pressure. And both glaucomatous patients can have a statistically normal intraocular pressure and non-glaucomatous patients can have statistically elevated intraocular pressure. The word statistically refers to two standard deviations on either side of the mean intraocular pressure in the entire population. When glaucomatous patients have statistically normal intraocular pressure, it is called normal tension glaucoma, and when non-glaucomatous patients have statistically elevated intraocular pressure, it is called ocular hypertension. In normal tension glaucoma, it is said that the intraocular pressure, although normal to low in these patients, is still too high for the survival of retinal ganglion cells of these patients, as it is seen that reduction of intraocular pressure reduces the risk of disease progression in normal tension glaucoma patients as well as in patients with glaucoma having an elevated intraocular pressure. Adult onset glaucoma can be broadly classified in two ways. We will go into the detailed classification of adult onset glaucoma in later sessions. In one classification, adult onset glaucoma is classified into open angle glaucoma and angle closure glaucoma. In open angle glaucoma, the trabecular meshwork is visible on gonioscopic examination of the anterior segment, and in angle closure glaucoma, the trabecular meshwork is partially or completely obstructed by the peripheral iris on gonioscopic examination of the anterior segment. The other method of classification of adult onset glaucoma is primary glaucoma or secondary glaucoma. In primary glaucoma, no cause can be identified which causes the glaucomatous damage, and in secondary glaucoma, a cause can be identified either in the history such as steroid use or trauma, or in slit lamp examination such as pigment dispersion and pseudoexfoliation, which has a possible role in the pathogenesis of glaucomatous damage. We may note here that in secondary glaucoma patients, we usually find an IOP in the statistically elevated range, but in primary glaucoma patients, the intraocular pressure can be either in the statistically low to normal range or statistically elevated range. In combined mechanism glaucoma, multiple causes may contribute to the glaucomatous damage, and three such situations are commonly encountered. In the first scenario, a patient diagnosed to have angle closure glaucoma based on gonioscopic examination after successful treatment and opening up of the angle continues to demonstrate raised intraocular pressure. In the second scenario, a primary open angle glaucoma patient develops a central retinal venous occlusion, following which there is neovascularization of the angle leading to secondary open angle glaucoma or secondary angle closure glaucoma. And in the third scenario, uveitis patients can present with glaucoma, and glaucoma in uveitis patients can be due to multiple mechanisms which raise intraocular pressure and which we will be discussing in the session on uveitic glaucoma. Being both an irreversible cause of blindness after blindness sets in, but preventable if detected early prior to onset of blindness. Glaucoma is a major public health problem. Global prevalence is estimated to be 3.5% in the population aged 40 to 80 years, with this figure 3.5% being an important one to remember. And prevalence in elderly individuals above 80 years of age is significantly more than that. With growth and aging of the population, total number of glaucoma patients are expected to increase in the future. Globally, although primary angle closure glaucoma is less common than primary open angle glaucoma, number of individuals blind from each of these two entities are nearly equal because of the higher morbidity of primary angle closure glaucoma, and the proportion of glaucoma patients still remaining undiagnosed is said to be 50% in Western countries and as high as 90% in Asia and Africa, signifying the importance of intensive screening programs. Risk factors for primary open angle glaucoma can be classified as demographic, ocular, and systemic. Demographic risk factors include race, age, and family history. Blacks of African origin, Hispanics of Latin American origin, and Asians are at a higher risk of developing primary open angle glaucoma than whites. In the Japanese population, 92% of open angle glaucoma patients have statistically normal to low intraocular pressures. Risk of glaucoma increases with age, and it is said that the risk increases up to tenfold from the fifth to the ninth decade of life, and the risk of glaucoma is said to increase up to tenfold in an individual with a family history of glaucoma as compared to an individual without a family history of glaucoma. Among ocular risk factors, we have intraocular pressure, refractive error, peripapillary atrophy, and corneal factors. And as we have mentioned, risk of glaucoma increases with increasing intraocular pressure starting from a level as low as 12 millimeters of mercury. And there is no cutoff IOP between normal and glaucomatous patients, which is very important to remember. Risk of glaucoma increases with increasing myopia, and a large zone of peripapillary atrophy is said to increase the risk of glaucoma progression in patients with intraocular pressure more than 21 millimeters of mercury. The ocular hypertension treatment study showed a thinner central cornea to be an independent risk factor for progression to glaucoma in patients with ocular hypertension, but this has not been established in East Asian populations. And some studies show a lower corneal hysteresis in patients with glaucoma. Systemic risk factors of primary open angle glaucoma include corticosteroid use in any form, either topical, ocular, inhalational, or systemic. And risk of glaucoma is said to increase with low diastolic blood pressures less than 50 millimeters of mercury, which results in low ocular perfusion pressure. But there is no evidence to suggest that raising the blood pressure in patients with low diastolic blood pressures reduce the risk of further progression of glaucoma. On the other hand, higher systolic and higher diastolic blood pressures are associated with higher intraocular pressures but have not been directly correlated with the prevalence of glaucoma. Some studies have suggested an association of primary open angle glaucoma with diabetes, and no definitive association of primary open angle glaucoma with smoking, alcohol, or caffeine use has been found, although there are anecdotal reports indicating these associations. Risk factors for angle closure glaucoma include demographic risk factors and ocular risk factors. No systemic risk factor for angle closure glaucoma have been found. Demographic risk factors include race, age, sex, and family history. East Asians are at a much higher risk of developing primary angle closure glaucoma than whites and blacks. Inuits or Eskimos have been found to be at highest risk of developing primary angle closure glaucoma. Risk of angle closure glaucoma increases with age, primarily because of the increased thickness of the crystalline lens, which we will soon discuss, and females are said to be 2 to 4 times more likely to develop primary angle closure glaucoma as compared to males. And primary angle closure patients also demonstrate family history because genetic factors determine ocular dimensions. We note here that sex is not a risk factor for primary open-angle glaucoma. The ocular risk factors for primary angle closure glaucoma include anterior chamber depth, refractive error, lens thickness, and corneal curvature. Primary angle closure eyes have mean anterior chamber depth less than individuals with open angles, and anterior chamber depth itself explains at least partially increased incidence of primary angle closure glaucoma with age, positive family history, and female sex. Hyperopia increases risk of primary angle closure glaucoma by decreasing the anterior chamber depth. Increased lens thickness predisposes to angle closure glaucoma, and lens thickness increases with age. Smaller radius of curvature of the cornea is associated with primary angle closure glaucoma, and no systemic risk factors for primary angle closure glaucoma has been found. In the OHTA study, up to 4% of the population has been found to have ocular hypertension with an IOP more than 24 millimeters of mercury but without glaucoma. Untreated, 10% of these patients show worsening disc and visual field changes at 5 years. So these patients require careful long-term follow-up. In the clinic, we often encounter patients with suspicious optic nerve appearance with or without borderline visual field loss, and these patients are said to be glaucoma suspects. And up to 16% of the population can be labeled as glaucoma suspects based on various definitions of suspicious optic nerve appearance. What is important to note is that intraocular pressures in glaucoma suspects are not taken into account to label them as having glaucoma, and glaucoma suspects like patients with ocular hypertension need long-term follow-up. And early onset glaucoma entities often demonstrate inheritance patterns due to highly penetrant specific mutations causing the disease. In other words, early onset glaucoma entities are caused by mutations in single genes. But later onset primary open angle glaucoma and primary angle closure glaucoma show a polygenic susceptibility pattern with a large number of genes and their interactions implicated in the causation of the disease, along with environmental factors contributing to the disease. And there is a method of nomenclature of genetic loci implicated in the causation of glaucoma, with GLC1 being used for loci with mutations causing open angle glaucoma, GLC2 being used for loci with mutations causing angle closure glaucoma, and GLC3 being used for loci containing mutations for congenital glaucoma. And each of these terms is followed by a letter to denote the sequence of discovery of that locus. Juvenile primary open angle glaucoma is primary open angle glaucoma with onset before 40 years of age, and 36% of JOAG patients have been found to have autosomal dominant mutations in myocilin gene, and this is the first glaucoma gene to be discovered. And mutant myocilin has been found to accumulate in the trabecular meshwork cells instead of being secreted, which is said to prevent normal functioning of the cells and ultimately cause death of the cells. 2 to 3% of normal tension glaucoma are said to be caused by autosomal dominant mutations in two genes, OPTN and TBK1, and these genetic mutations are said to stimulate apoptosis. A large proportion, though not the majority, of primary congenital glaucoma are inherited, and 4 genetic mutations have been identified. Autosomal recessive mutations in CYP1B1 gene and LTBP2 gene. LTBP2 mutations are also found in several entities which are characterized by compromised zonular support of the crystalline lens. The other 2 mutations causing primary congenital glaucoma are autosomal dominant in nature and are in ANGPT1 gene and TEK gene. Axenfeld-Rieger syndrome has been known to be caused by autosomal dominant mutations in 2 genes, PITX2 and FOXC1. Recently, autosomal recessive mutation in CPAMD8 gene has also been found to result in Axenfeld-Rieger syndrome. From a clinical standpoint, the inheritance pattern of aniridia is very important to understand. Aniridia patients can present as inherited aniridia or sporadic aniridia. Sporadic cases of aniridia do not have a family history, while inherited cases of aniridia do have family history. Inherited cases of aniridia are usually caused by mutations in the PAX6 gene in chromosome 11p, but sporadic cases of aniridia are due to large deletions of the same chromosome involving the same gene. But since these are large deletions, these deletions may involve the nearby Wilms tumor or WT1 gene. So large deletions in this region of chromosome 11 may result in absence or abnormality in both PAX6 and WT1 gene, and this may result in WAGR syndrome, which comprises of Wilms tumor, aniridia, genitourinary abnormalities, and mental retardation. So patients with sporadic aniridia should be screened for abnormalities in the WT1 gene, and this is very important to remember. As we have discussed, POAG or primary open angle glaucoma is up to 10 times more common in individuals with family history than in individuals without family history. Family-based linkage analysis have identified 3 genes which may contribute to POAG. These include the MYOC gene, which is also implicated in juvenile open-angle glaucoma, OPTN1, which causes normal tension form of primary open-angle glaucoma, and WDR36. But genome-wide association studies have located 16 genes and loci statistically associated with POAG, and these are called susceptibility alleles. In family-based linkage analysis, genetic studies is based on family members affected with the disease, but in genome-wide association studies, a large number of patients having the same disease undergo genetic testing in an attempt to find out the common genetic mutations in them. So in primary open-angle glaucoma, instead of a single gene causing the disease, genetic interactions and environmental influences are considered to be more important. Mutations of MFRP gene has been found to be a causative factor for nanophthalmos, which can be associated with primary angle closure glaucoma, and genome-wide association studies have located 8 genes and loci statistically associated with primary angle closure. Pigment dispersion syndrome can be inherited in an autosomal dominant manner, and the locus has been identified in chromosome 7. And mutations in LOXL1 gene is said to contribute to pseudoexfoliation syndrome. LOXL1 mutations have also been found in a large number of normal individuals, suggesting that the genetic defect is necessary but not sufficient for causation of pseudoexfoliation. And genome-wide association studies have identified CACNA1A gene as a causative factor for pseudoexfoliation syndrome. Genetic testing and counseling helps in identifying a patient at risk of glaucoma at an early age prior to the onset of structural and functional changes of glaucoma, and it also helps in identifying the risk of a future offspring to develop glaucoma. In addition to genetic factors, environmental factors are also known to increase the risk of glaucoma, and these include sun and low ambient temperatures, which have been particularly implicated in pseudoexfoliation syndrome, higher levels of serum cholesterol, and use of statins, estrogen exposure, and lead poisoning. So to recap the salient points, glaucoma is a progressive optic neuropathy with characteristic loss of retinal ganglion cells and axons, optic disc excavation, and visual field loss. Glaucoma is classified as open angle or angle closure based on visibility of the trabecular meshwork on gonioscopy. Combined mechanism glaucoma can also occur. Glaucoma is also classified as primary or secondary based on whether an associated condition is present which causes the glaucoma. Global prevalence of glaucoma is estimated to be 3.5% of the population. Risk factors for primary open-angle glaucoma include race, older age, family history, higher intraocular pressure, myopic refractive error, peripapillary atrophy, thinner central cornea, corticosteroid exposure, and low diastolic blood pressure. Risk factors for PSEG include race, older age, female sex, family history, smaller anterior chamber depth, hyperopic refractive error, thicker crystalline lens, and smaller radius of curvature of cornea. Mutations in numerous genes have been identified in glaucoma patients by both family linkage analysis and more recently by genome-wide association studies. And a few notable examples include MYOC in juvenile open-angle glaucoma, OPTN and TBK1 in normal tension glaucoma, CYP1B1, LTBP2, ANGPT1 and TEK in primary congenital glaucoma, PITX2 and FOXC1 in Axenfeld-Rieger syndrome, and PAX6 in aniridia. Thank you for listening.